Hi, Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. The question of which patients benefit from osteoclast inhibitors is a very important question and one that has been addressed by the NCCN guidelines. And this is particularly important in the adjuvant curative setting because both disease-free and overall survival are improved with the addition of a bisphosphonate, an IV or oral bisphosphonate in the adjuvant setting for patients. The understanding of osteoclast inhibitors is underscored by the biology of the vicious cycle, where micrometastatic disease in the bone elucidates factors that activate osteoclasts, which in turn lead to lytic destruction of the bone, which then from the bone liberates growth factors that support the growth and survival of micrometastatic disease in the bone. So that vicious cycle is interrupted by bisphosphonates. And bisphosphonates may have other salutary effects, such as killing of tumor suppressive macrophages, which ingest the bisphosphonate and can die and be killed by the bisphosphonate. So a number of mechanisms can underpin the benefits of osteoclast inhibitors in the adjuvant setting. So there has been a meta-analysis performed by the Oxford Overview group of approximately 20,000 women, postmenopausal women, most of them, that had been evaluated with either an oral bisphosphonate, mainly clodronate, which is not available in the US, or IV pamidronate or IV zoledronic acid. And these patients have been treated either every 3 months or every 6 months with an oral or IV bisphosphonate. And that meta-analysis showed that the bisphosphonates did not benefit premenopausal women, but did benefit postmenopausal women with regard to disease-free survival, distant disease-free survival, overall survival, and survival-free of bone metastasis. So specifically bone metastasis-free survival. And the benefits are in the order of a 25 to 30% reduction in the risk of recurrence in the meta-analysis. So a very large impact on disease-free and overall survival. And the national guidelines now call for 3 to 5 years of an IV bisphosphonate or an oral bisphosphonate. Generally speaking, we utilize IV zoledronic acid every 6 months for 3 to 5 years. I generally go by the level of risk. If someone's very high risk, node positive disease, I will often utilize 5 years of the IV bisphosphonate. If they're lower risk, I would utilize 3 years of the IV bisphosphonate. We don't have head-to-head data on the duration. The premenopausal population, however, does not benefit from this. There is no group of patients that is in the meta-analysis that does not benefit from the bisphosphonate, the adjuvant bisphosphonate, regardless of tumor size, nodal status, postmenopausal age, grade of the cancer, or estrogen receptor status. Though there were fewer ER-negative patients available in the meta-analysis, the estrogen receptor negative patients also benefited from the bisphosphonate. So basically, all patients with any risk who are postmenopausal or premenopausal patients receiving an LHRH agonist would also be considered a postmenopausal benefit from an adjuvant bisphosphonate. There was a study that was conducted in premenopausal patients called the Austrian Breast Cancer Study Group 12 trial, the ABCSG 12 trial. This was in premenopausal women, and only a very small minority had had chemotherapy. And so they were getting endocrine therapy, and they were all given an LHRH agonist goserelin, and they were randomized to tamoxifen versus anastrozole for just 3 years. And there was a secondary randomization to every 6-month zoledronic acid versus not for 3 years. And the addition of the zoledronic acid impacted not only disease-free survival, but favorably impacted overall survival. So in our premenopausal patients who are on an LHRH agonist, it's very important to consider the addition of the zoledronic acid in the curative setting. In addition to the curative setting, here the bisphosphonates are very important as a prophylaxis against skeletal-related events in any patient who has bone metastasis in the metastatic setting. And we know that giving the bisphosphonate, such as zoledronic acid, every 3 months is equivalent to a monthly schedule. So we can start right off with every 3 monthly IV zoledronic acid and decrease the incidence of skeletal-related events, which means a fracture or the need for surgical intervention or the need for radiation therapy to the bone. Those are the skeletal-related events, which are definitely decreased, and also hypercalcemia is also very definitely decreased with the utilization of a bisphosphonate. So that's also standard of care. It's not clear how long the bisphosphonate should continue in the metastatic setting. Certainly in someone with active bone metastasis, they would continue to receive the IV zoledronic acid every 3 months. But for patients who have more quiescent bone disease that's well treated, it wouldn't be unreasonable to decrease it to every 6 months, as is done in the adjuvant setting. The use of antibodies against rank ligand, the denosumab, also have proven salutary effects to decrease skeletal-related events in the metastatic setting, and that's a subcutaneous injection of denosumab monthly. There's no advantage of the denosumab over the bisphosphonate unless a patient has renal insufficiency, in which case the denosumab does not have a renal toxicity, but otherwise they are equivalent in terms of their efficacy. The denosumab was evaluated in the adjuvant curative setting in the DCARE prospective phase 3 trial, but unfortunately did not improve outcome with regard to disease-free survival, distant disease-free survival, but it did improve bone metastasis-free survival. But this did not lead to an indication for denosumab in the adjuvant setting, nor it's not been included in the national guidelines in the curative setting. But I always do encourage my patients to take an IV bisphosphonate, the IV zoledronic acid, every 6 months for 3 to 5 years if they're postmenopausal or if they're premenopausal on an LHRH agonist, because I'm a big believer in these guidelines, and it's really hitting that biology of the vicious cycle that supports the growth and survival of the micrometastatic disease in the bones.